Okay, so I think we'll just get started. I appreciate some people are still coming in, but just to start off and just welcome everyone to tonight's session. So we're going to be talking about cobalamin in dogs and cats, diagnostic clues and therapeutic roles. So we're very pleased to have Sue Yee Lim from Texas A&M with us tonight. Just very quick housekeeping. So we're going to be recording the session tonight. So if you miss anything at all, I'll send that out so you can watch it back. The plan for tonight, Sue will be chatting with us. Then we're going to have time at the end for a question and answer session. So you should notice a Q&A box at the bottom of the page. You can add questions in as we go, or you can add them at the end, and we'll try and go through as many of them as possible as we can at the end of the session. So just quickly, I'll introduce myself for those of you who don't know me. I'm Jill McMaster. I'm one of the 10 vets, I think it is, we have at Protexin. So if you're asking for advice on products, chances are you'll be speaking to myself or one of my colleagues. So one of the things we get asked quite a lot, we get asked quite a lot of questions about B12 and cobalamin, which is obviously why we thought this would be quite a good session to have. So products we have our Cobalaplex, which is our oral cobalamin and folate supplementation, which has also got gastrointestinal microbiome support. We also have our procolon intragenic, that's acting to support intestinal health, modulate the immune system, stabilize the microbiome, and also it supports normal cobalamin levels. And we also have our ProEnzor product as well, which is supporting pancreatic function, including cobalamin levels. So that's why I thought it's such a useful topic. And that's why we've asked Sue to come along tonight to teach us more about cobalamin and its uses. So to give Sue her proper introduction, Sue graduated with a DVM from the University Putra, Malaysia in 2009 and went on to continue her studies at Hokkaido University. So she graduated with a PhD in 2014 and her research was focused on the application of contrast-enhanced ultrasound for the diagnosis of acute pancreatitis in dogs. So after obtaining her PhD, she returned to Malaysia, where she taught as a senior lecturer before continuing her research on lipases in the GI laboratory at Texas A&M. So she's completed a small animal internal medicine specialty internship and residency at Texas A&M University, and she currently serves as an assistant professor at the same institute. So our research interest includes diagnosis and treatment of pancreatitis in dogs and cats. So I'm sure you'll agree, Sue is a great person to be discussing this topic with us tonight. So I will hand it over. Thank you, Sue.
Thank you, Jill. And I hope that everyone is able to see the slides.
Yeah, they look good.
Okay, perfect. So I know that introduction says that, my focus is in the pancreas, but truly I love anything that has to do with the gastrointestinal tract. And so cobalamin is something that, I use in my daily practice. I don't think I can survive without it. And so I think that this is a really good talk today. And thank you to Protexin for inviting me. So conflict of interest, I am an employee at the GI lab at Texas A&M, and we offer measurement of cobalamin and methylmalonic acid concentration on a fee-for-service basis. So the objectives of, our talk today, we are going to be looking at what is cobalamin, or known as B12 vitamin, cobalamin metabolism. We'll go through common conditions associated with cobalamin deficiency, its use in both diagnosis and therapy, and we're going to look at a patient-centric approach to this. So cobalamin is a water-soluble vitamin that's essential. It means that you can't make it, you have to get it from your food. The good thing is that it is usually abundant in food source of animal origin, such as meat, egg, milk, but it's not present in plants. So in people who are vegan, they can occasionally be deficient. So if you are deficient, it is likely due to malabsorptive process and unlikely to be dietary just because of what we are feeding our pets. Now, cobalamin is an important cofactor for two enzymes that are very important to maintain cellular function, and that is methylmalonic CoA mutase, which converts methylmalonic acid into succinyl CoA, which is needed for the Krebs cycle. It is also a cofactor for methionine synthase that will convert homocysteine to methionine. And when cobalamin is deficient, there is a buildup of methylmalonic acid and homocysteine. Now let's have a look at cobalamin metabolism. When we take in cobalamin, it is bound to protein. And in the stomach, cobalamin is then released from dietary protein by the action of pepsinogen and gastric acid. This free cobalamin is going to then bind to haptocorin, also seen as R protein in this slide, and that is to protect cobalamin from being used by bacteria within the proximal GI tract. In the duodenum, pancreatic proteases will then separate cobalamin from haptocorin. And in dogs, intrinsic factor is produced predominantly in the pancreas. And intrinsic factor will then bind to cobalamin. And this binding of intrinsic factor to cobalamin is really important because this enables it to be taken up for our use in the distal small intestine through the cobalamin receptor. So the complex of cobalamin and your intrinsic factor is very important. Without, the intrinsic factor, the endocytosis will not be able to take place. And in the enterocytes, cobalamin will then be separated from the intrinsic factor, and it will be bound to transcobalamin, which will then circulate cobalamin in the bloodstream. So serum cobalamin is measured at reference labs using automated chemiluminescent assays. And so the reference interval is both lab dependent and species dependent. So you can see here that our canine range goes from 251 to 908. We use nanogram per liter. At other labs, they may use picogram per mil, and they are equivalent. So our feline reference interval goes from 290 to 1500. So it's important that you note what the reference intervals are, what the units are, and there are also some labs that will measure it as picomole per liter. So you have to do some conversion to change it into similar units. Now, it's important to note that low serum cobalamin is not equivalent to cobalamin deficiency because it is not measuring how much cobalamin you have at the cellular level. And so, again, what you're measuring in blood does not always equate to what you have within the cell for all those enzymatic functions to happen. And so when we say cobalamin deficiency, we mean a low serum cobalamin coupled with an increase in the byproduct methylmalonic acid. So you have to have both low serum cobalamin and high MMA. and that's defined as cobalamin deficiency. So just saying that you have low cobalamin means that your serum concentration is below the reference interval. It doesn't tell you what's happening within the cellular level. And if you are normal cobalaminic, it means that your levels are within the reference interval. And if you are hyper, it means that you are above the reference interval. Now, this is of little significance at this time, but abnormally high serum cobalamin concentrations can occasionally happen in cats with liver or neoplastic disease. It's something that we are starting to understand, but at this time, high cobalamin levels are something that we do not worry about. So again, just reminding you that low serum cobalamin does not equal cobalamin deficiency. And you can see this is a chart, a graph of cobalamin on the x-axis and methylmalonic acid, which is this byproduct that builds up when you have cellular deficiency. And we separate patients out by different beans of cobalamin. So how much cobalamin we have, we separate them out. And the reference interval, that we see in our patient is somewhere here, 250 to about 1,000. And what you can actually see is that in yellow, we're showing patients that, according to their cobalamin levels, have increased methylmalonic acid. And you can see our cutoff in our lab is about 1,200. That majority of those abnormal patients do have low cobalamin. So we actually found that 46% of patients with cobalamin below 250 had a high MMA. So that's 1 out of 2 patients with low serum cobalamin. But we can also see that when cobalamin is within the low end of that reference interval, we can see up to 20% of patients actually having high MMA. And this tells us that, down at the cellular level, they are deficient. So 1 out of 5 of your patients will be deficient. And so the internal cutoff that we use when evaluating our patients would be closer to 400 nanogram per liter when we say, does this patient have GI disease, or do I need to start thinking about supplementation? So that 400 cutoff is what I usually use. So what does, cobalamin deficiency cause in people? It's associated with cardiovascular disease. It can cause demyelinating neuropathies. It can cause dementia, and most famous would be pernicious anemia that, used to cost a lot of lives before they found out what actually was happening was cobalamin deficiency. So common conditions that we see in dogs and cats is associated with exocrine pancreatic insufficiency, abbreviated as EPI, and that's because the exocrine pancreas is that main source for intrinsic factor. So remember that the only way that cobalamin can be absorbed in the distal intestines is if it is bound to intrinsic factor, and that's how it gets into our body. And in chronic severe ileal disease, that is the distal small intestines, it's where cobalamin is being absorbed. Less than 1% is absorbed throughout the other parts of small intestines. So in chronic enteropathy, and this is the broad umbrella term for any GI disease that persists for more than 3 weeks, it could be inflammatory in nature, it could be neoplastic, it could be infectious, but chronic severe ileal disease is what we think about when we think about cobalamin deficiency. And there are some genetic diseases called Imerslund-Grasbeck syndrome, and this is seen and reported in beagle and border collies, where they have congenital disorders of cobalamin receptor, so they are not able to absorb the cobalamin in their diet. And there is something called this region-specific hypocobalamin seen in the UK, where staffies and some mixed breed dogs have been reported to have low cobalamin, but this is not seen in staffies in the US. So when we have cobalamin deficiency, you can see gastrointestinal signs, and that is, you see patients being lethargic, they're inappetent, they may have vomiting, diarrhea, weight loss. You can also see patients with anemia when they have cobalamin deficiency, and you can see peripheral and central neuropathies in this patient. And in puppies and kittens, they will also fail to thrive. And when you see this in puppies and kittens, then you think about, is this something that they have from birth? So when I think about cobalamin as a diagnostic tool, I know that hypocobalaminemia is common in dogs and cats with EPI and chronic enteropathy. In fact, about 80% of dogs and cats with EPI have low cobalamin, and about 40% of dogs and cats with chronic enteropathy have low cobalamin. So I use this as a biomarker for EPI and chronic enteropathy. If I see that it's low, then that gives me more evidence that my patient does have, some kind of chronic GI disease or EPI. But in looking at, the percentages of patients that actually have this disease and also have low cobalamin, if I don't see low cobalamin, it does not rule out the presence of EPI or chronic enteropathy. When thinking about using biomarkers in helping us to diagnose or rule in or rule out any one disease, I think of it as multiple little tools that I can use to help me to, refute or to make a differential diagnosis go higher on my list. So having normal cobalamin does not rule out these conditions, especially when your patient is showing you clinical signs of chronic enteropathy. So let's start off with a really simple case. This is Miley. She's a 7-year-old spayed female boxer, and you can see just how thin this girl is. Her her chief complaint was severe rapid weight loss despite eating 12 times of her daily caloric requirements. So I know that you must be thinking of some kind of disease at this time point. I'm thinking about that too. And so, how do I get about to my answer? I did a GI panel that consists of cobalamin, folate, PLI, and TLI. So PLI looking at pancreatic lipase, TLI looking at, does this patient have EPI? So I see that this patient has really low cobalamin. Again, the magic number that we use in our lab is 400. So although it's it's below the reference interval, and that's really abnormal, but anything below 400, I will be excited. So this dog doesn't have pancreatitis. The folate is normal for this patient, no proximal GI disease, and the TLI is so very low. So this is a patient that we've diagnosed with EPI, and the treatment for it is pancreatic enzyme replacement therapy. We've also started her on probiotics, and she received B12 supplementation lifelong. So this is her before picture. You can again just appreciate how cachectic she is and look at this waist. And within 3 weeks at our first recheck with her, she has gained 4 kilograms. She has improved body and muscle condition score. And this is a really happy case for us. Now, when we're thinking about approaching, so that's EPI, simple case. Now, when we think about the approach to chronic enteropathy, I like to think of it as, is this an extra GI disease versus is this a primary GI disease? And when I think about extra GI diseases, my big categories followed by my specific diseases. So I think in big buckets. Is this an endocrinopathy? Am I looking at Addison's disease? Am I looking at hyperthyroid for an older cat that's losing weight and having chronic GI signs? I think about hepatic disease and liver failure can occasionally confuse us. I look at, does this patient have significant kidney disease? Are they showing GI signs because of their chronic kidney disease or their uremic status? I'm thinking about pancreatic disease. Does this patient have EPI? Does this patient have chronic panc? Does this patient have neoplasia, which is very uncommon? And so what I do is my minimum database, I do CBC, chemistry, urinalysis. I might add in a TLI to evaluate for EPI. I may add in a baseline cortisol to evaluate for Addison's disease based on my degree of suspicion. And when everything is telling us that this is not extra GI, then I think about my primary GI disease. Is it infectious in nature? Do I have parasites, fungal, bacterial, algal? And depending on where you are practicing, those differential diagnoses will change a great deal. I practice in Texas, so we have everything. Do I think about neoplastic diseases, especially in those chronic GI crunchy cats? They tend to, be on a spectrum of intestinal inflammation, and when that's chronic, they develop small cell lymphoma. Do I think about anatomical diseases like lymphangiectasia? Do I think of this as being just a drug-related or toxin-associated signs in the GI tract, or do I think of it as an inflammatory disease? And so this talk is not going to tell you or teach you step by step how to diagnose chronic enteropathy, but these are some of the big things that I think about. The EPI diagnosis is simple. The chronic enteropathy diagnosis takes a little bit more time. So to look at my primary GI disease, I, of course, would do a fecal parasite screen. Again, depending on where you are, you may want to tailor that. But often I reach for cobalamin and folate because I know that, the chances of it being a primary GI disease, especially when I have cobalamin and folate being low, goes up on my differential diagnosis. And so when I think about cobalamin as a treatment, we know that cobalamin deficiency is a negative prognostic factor for patients with EPI or patients with chronic enteropathy. And therefore, it's really important for us to evaluate cobalamin and to supplement cobalamin when there is a deficiency. So these are some good papers that talks about cobalamin and folate as prognostic factors, and also, what and why it's important for us to actually treat them. So I will supplement cobalamin regardless of the underlying etiology, whether it's EPI, whether it's chronic enteropathy, I will supplement them. And when I do that is when the serum cobalamin concentration is at the lower end of the reference interval. And so for me, that's about 400 nanogram per liter at our institution. And when I'm thinking about the route, traditionally, cobalamin supplementation is done through subcutaneous injections. But recently, oral supplementation has been shown to be similarly effective in normalizing serum or cellular cobalamin concentrations in dogs with EPI or chronic enteropathy. And so when we think about parenteral cobalamin supplementation, we commonly use cyanocobalamin because it's widely available and it's inexpensive. The protocol that we use is a subcutaneous protocol, so it's not painful. We use it, we give the injection once weekly for 6 weeks. And then we dose it 1 month after the last weekly injection. And I will retest cobalamin level a month after the last dose. So in regards to dose, for cats, they're all about 5 kilogram. So we use 250 microgram per cat. And you can see that this is a 1000 microgram per meal. And so this is only 0.25 meal that's given sub-Q, and it's really not painful. Sometimes we do get owners to do this at home. So we do a tech appointment and we teach them how to do a sub-Q injections. And so this is really easy because cats are very stressed in the hospital. Now, for dogs, this is based on body weight. You can see that this is in pounds, so you just have to do some conversion. So depending on how heavy they are, they receive 250 to 400 to 600. I never remember this number. Whenever I need to dose them, I just search Texas A&M, GI Lab, Cobalamin, and I get this chart and I tell my nurses how much they need. Again, this is a sub-Q injection. Now, lately, there has been reports about using another form of cobalamin, and that's hydroxycobalamin. This is used as an intramuscular injection, and so it might be just a little bit more painful. You might want to avoid where the nerves are. So this is not one where I will get the owners to do the injection at home. I'll get them to come back to the hospital. And when we use hydroxycobalamin is when cyanocobalamin is not enough to bring up those levels. Now, honestly, I've never used hydroxycobalamin in our institute just because cyanocobalamin has worked pretty well for us. And so when we think about oral cobalamin supplementation, this is a daily medication for 12 weeks, and we retest a month after the last dose to tell us, is there a need for continual supplementation? And so the good thing about Cobalaplex is that it contains both cobalamin and folate. It's really hard to find folic acid as a smaller than a 400 microgram tablet or capsule because they're all made for pregnant women. And so it's really challenging to find 200 micrograms. So this is something that has a combination. And so the dose that we use, again, 250 microgram per cat, and dogs, this is based on body weight. Again, I never remember this. I just go and look at our Texas A&M GI Lab cobalamin, and you will be able to find the dose. So, what if you cannot measure or remeasure cobalamin? I've given, talks about, cobalamin and folate back in Southeast Asia, and to measure it is very expensive. And I understand that we have a worldwide audience. So, what happens when you cannot supplement? Now, you know that dogs and cats with EPI and cobalamin, there's a high percentage of them that actually have low cobalamin. And knowing that this is a supplement that is safe for us to supplement, it's water soluble. So if it's not needed, it is excreted. There is little contraindication to supplementation. So for patients with EPI, I will say lifelong supplementation for you because you can't produce intrinsic factor. You're not going to absorb it. But for patients with chronic enteropathy, this really depends. And I hope that the next case will be a good highlight for how we use it. So before we go to that, what I always, think about when I think about treating with cobalamin is that it is always an adjunct therapy. It is important for you to optimize the underlying condition. So whether your patient has been diagnosed with EPI, you definitely need pancreatic enzyme replacement therapy, and they need to be on a highly digestible diet. Doing cobalamin injections or oral supplementation without tweaking with enzyme therapy or diet management, you're not going to optimize patient care. Now, with chronic enteropathy, it's a little bit more complicated. You do have to modulate their diet. And the good thing is that greater than 70% of patients with chronic enteropathy do well on some sort of diet if you can find the right one. So you may also need to tweak with steroid, whether you're using it as an anti-inflammatory or you're using it as an immunosuppressive. You may need to reach out for a second-line immunosuppressive agent. You may need to implement microbiota modulating therapies. We like to use fecal microbiota transplant and probiotics. And there are many other supportive therapies that you need to help optimize that care for your patient with chronic enteropathy. So I think that it's really important, and something that you have to remember is that cobalamin cannot be used as a sole therapy. It's not going to work. So let's look at this case. Sparrow is a patient of mine. He's a 3-year-old male neutered, really handsome husky shepherd cross. And he came to us with a history of chronic, intermittent vomiting, hyporexia, weight loss, mucus covered feces that did not respond to tylosin. So I'm sure that from this history, you probably are thinking about a patient with number one, chronic enteropathy that is mixed bowel in origin. So this owner loves to take pictures of her dog's poop, and she loves showing it to me. And this really caught my eye because you can see that there is this almost sausage-like casing that's kind of like white that's encasing the poop. So this is mucus. And this is poor Sparrow. You can see that he has got, a trough full of like food, and he is showing zero interest in it. So on his blood work, we do see moderate eosinophilia of 2.6 thousand. A patient that's unwell, you should see a eosinophil count of lesser than 500. He wasn't very sick when he came to us, but anything that, that is kind of like creeping in the thousands makes me excited. On his chemistry, his albumin was unremarkable. If you look at the numbers alone, albumin was 3, cholesterol was 197. So these numbers do not scream protein losing enteropathy. Infectious disease testing, he tested negative for common parasites, fungal, fluke infection. On his abdominal ultrasound, it was unremarkable. So very boring at this time. So what we followed up was we did a GI panel that was extended. We'll go through the result one by one. So TLI of 18.8, this is a patient that does not have EPI. Great. A CPLI of less than 30. So reference interval 0 to 200, that tells me that my patient is not having this clinical signs because of chronic pancreatitis. I looked at the cobalamin. Well, 432, technically it's within the reference interval, but it is on the lower side of where, our internal cutoff of 400 is. So plus minus. And then folate, unremarkable. And cortisol was 1.8, so less than 2. I cannot rule out Addison's disease, so we did an ACTH stim, and his ACTH stim was 6.2, so that rules out Addison's. I'm not thinking about Addison's anymore. At this time point, I'm kind of leaning towards, is this GI in nature? So he was doing quite well. He's a very stable patient. So we said, why don't we try some treatment involving food trial, probiotics, and cobalamin supplementation. His food trial was challenging because of his hyporexia. So if you can't get a patient to eat the food that you want to try out, it's really challenging to do a food trial. So this patient, we did a GI biopsy and we found that this patient has lymphoplasmacytic. These cells are associated with chronic inflammation, and he has inflammation that's seen in his stomach. And he also, in addition, had eosinophilic duodenitis, ileitis, and colitis. So he has inflammation throughout his entire GI tract, and that's manifested by both his hyporexia and also his colitis and that weird mucus on his poop. So it really helps when you couple your GI signs together with where the localization of disease is with your biopsy results. So, because this patient was such a picky, finicky eater, and I could not get him to eat a diet that's therapeutic for him, I started with prednisone at 1.8 mg per kg per day. Now, the amount of steroids that we use in North America or in US is much lower than what our counterparts in the UK will use of like 2 milligram per kilogram twice a day. We rarely reach for such high dose. In fact, we max it out usually at 50 milligram per dog per day because we know that for larger dogs, their immunosuppressive dose is reached pretty quickly. And I started him on a hydrolyzed diet and I continued him with cobalamin and probiotics. And so you can see that this is his poop before his therapy, and this is how his poop looks like after he started treatment. So that's pretty good. Now, with his progression, he has clinically improved, but he has a lot of side effects associated with his pred. So what we did was that we slowly tapered off his pred and we continued him on his hydrolyzed diet alone because remember, 70% of your patients could be managed with just diet therapy. Now, I rechecked with him a month after discontinuing his pred. He was doing great. He has gained weight, but he was reluctant to eat in the morning. So I was thinking, what's going on with this patient? And what I did was I looked at his biomarkers. Again, you can see that for this specific patient, his peripheral eosinophilia has returned. His albumin initially was at 3, and when we got him to a much better place, he's around 3.5. His albumin has dropped to 2.9. So, although technically, again, this is within the reference interval, for this specific patient, this is low. And when we check his cobalamin level without supplementation, it has gone down to 372. So I know that his GI disease has relapsed while he's not on steroids. So my plan for this patient was to start him on budesonide, which has lesser systemic absorption, therefore lesser systemic side effects. He was maintained on a hydrolyzed diet, but that didn't control his disease. So we changed his diet to a novel protein diet, and this is a bison home cooked diet. And we also restarted his cobalamin supplementation. We went with an injection protocol. Now, we follow up a month after his last cobalamin dose. Clinically, he's doing great, but he has ups and downs with his appetite. And my question is he bored versus is this a flare up of his disease? And because I know that he has great biomarkers for us to follow, I looked at his peripheral eosinophilia, that was resolved. I looked at his albumin, it was 3.9, so this is very normal for him. And cobalamin, even after a month after his last cobalamin dose, was 840. So I know that he is clinically in remission. He was just bored with having one kind of food every single day. So currently, we've tapered him to the lowest dose possible of budesonide of 1 milligram per day. We continued him on his novel protein, home cooked diet, and also probiotics. And his last cobalamin at his recheck was 417. That is a low normal, but this was him unsupplemented. It was low normal. I did not choose to supplement it because I knew that this was a really good biomarker for him, and I could follow all of this biomarker when he has some form of evidence of relapse, and then I can supplement him again. And so, you know, I really like to use cobalamin as both, diagnostic and also a treatment tool. And so, in conclusion, cobalamin is really important for diagnosis and prognostication tool. I screen any of my patients with chronic GI disease. If it's abnormal, it gives me more evidence that I'm dealing with a primary GI disease or EPI. Now, common conditions will include EPI and chronic enteropathy. And it's really important that you use this as an adjunct therapy. It is not meant to be used as a sole therapy. As you can see in Sparrow's case, we do a lot of other modulation and we use cobalamin both as a diagnostic and therapeutic tool. Now, for patients with EPI, they do need to have lifelong supplementation. And the need for supplementation in patients with chronic enteropathy really depends on that individual patient. Now, I know that we have just another 3 more minutes. Before I end, I have just a kitty cat case. I think that we have enough time for a Q&A. So this is Betsy. She's a 6-year-old spayed female domestic short hair that was presented to us for being hyporexic for about a month. She's got weight loss and she's polydipsic. She was extremely lethargic and she vomited once when she came to see us. On a physical examination, she was laterally recumbent. CBC was unremarkable. On her chemistry, she's got really high glucose. She's got high liver enzymes, and her TBL is also really high. On her urinalysis, we saw that she has glucose and ketones. Her blood ketone was 2, and her blood gas pH was acidic at 7.2. So this patient has DKA. And on our diagnostic, we saw that this patient had evidence of acute pancreatitis where the FPLI was greater than 50, so really high. And we could also see on our ultrasound that this patient has intestinal layerings that are very abnormal. And so I followed this with a cobalamin, and it shows us that this patient's cobalamin is really low at 260. So, looking at this patient, triaditis is a very common condition in cats. We have liver enzyme elevation, so that's organ number 1, cholangitis. We do have evidence of pancreatitis, that's organ number 3, and we do have evidence of chronic enteropathy that is manifested as this abnormal layering of its GI tract and also cobalamin. So that's organ number 3 for this patient with triaditis. Now, Betsy was a really challenging case because she had DKA not once, not twice, but 3 times because we could not optimize the 3 components of her triaditis. And so this is how I use cobalamin, both again as diagnostics and also treatment in my patients with suspected chronic enteropathy. All right. And I think that's all I have for you. I welcome any questions.
Thank you so much, Sue. That was absolutely brilliant. That was really, really good, really, really useful stuff. in there. So we've got some questions already. If you go to the
Mm-hmm.
Q&A box, if anyone wants to add any questions, please do. But otherwise, what I'll do is we'll just go through the list here.
Mm-hmm.
So our first question we have is just an anonymous one, but it says, if you have a cobalamin in range, but from April to June, it's dropped from 800 to 700, would you recheck it? And if so, when? So this cat's got IBD.
Probably I won't. Like at 7 to 8, like 800 to 700, I probably will not recheck it. But again, your patient tells you what's going on. So cobalamin is just one biomarker that you can use. So if the cobalamin is not low, but the cat is obviously screaming to you, hey, I've got an issue, right? Then if diet doesn't work, if it's hyporexic, I may want to put in a feeding tube so that we can do a diet trial. If I suspect that this patient may have lymphoma, I will reach for like a scope. I will try to get a diagnosis, even if the cobalamin is normal. Now, I say that with a caveat because a cobalamin level of 700 to 800 is unlikely to be seen in a patient that has, for example, lymphoma. Those patients are usually very low. So I can't use it as a marker to rule out lymphoma, but I would think that the cobalamin is not giving me an answer. I may try other things. I may recheck a patient if they're closer to that 400, but at 7 to 800, you're probably just that biomarker is probably not a great one for that kitty cat.
Perfect. Thank you very much. So next question we've got here from Gordon. Would you always start with the injection protocol in the acute stages and then change to potentially oral once remission has occurred, for example, with
Mhm.
EPI?
Okay, so for EPI, actually, the research that was done at the GI lab actually shows that dogs on oral supplementation have both normalization of their serum cobalamin and also their methylmalonic acid. So at the cellular level, it's being corrected. We don't know how it happens. Where is the intrinsic factor coming from? That's another field of research that we will be looking at, but there must be some extra intrinsic factor pathway for absorption that we don't quite understand. So for dogs with EPI, I commonly just use oral supplementation because we know that they need it for lifelong. And their true disease is not truly a GI disease, it's the lack of pancreatic enzyme. So absorption should not be an issue. Now, for patients with chronic enteropathy, I think about if this patient has 10 medications, I would like to prioritize getting maybe steroids in, and I would like to prioritize getting cyclosporin in. I would also like to prioritize ondansetron, maropitant, XYZ medication, fiber supplementation. Then in that case, I will reach for an injection and I'll get them to go to the vet weekly if I don't trust that they can do a good job. If I see that they're elderly people, I say, come in, we will do the injections because it might be a through and through injections. They cannot see, they don't know. So I tailor it based on my patients. If I've got patients that hate oral medication, then I'll just say injection it is. If I've got patient that eats oral medication in marshmallows, vegan usually, because we don't want protein to be, affecting the diet trial. If the owners say they're very food motivated, like they don't like their food, but they'll eat marshmallow, I'm like, okay, then oral supplementation it is. But if I've got a patient that has low cobalamin, even on oral daily supplementation, then I know that the GI tract health has not been optimized and that absorption is challenging. In that case, I bypass it. I may give steroid, I may give cobalamin injection, sub-Q, and that just takes away the whole idea that you need the GI tract to be in good condition to absorb. So there are many ways to do it. I base it based on the patient, its temperament, its appetite, how many medications I have to give, the owner, and also just what is easier.
Perfect. Thank you very much. So this one
Mhm.
here is from Angela. She says, thank you for your nice talk. I wanted to ask you about the prevalence of hypocobalamin in dogs with pancreatitis.
Well, I don't think that we've actually looked at dogs with pancreatitis and low cobalamin. I do not tend to supplement them.
Okay, no, that's absolutely fine. Thank you very
Hmm.
much. So Caroline's just telling us it's a brilliant webinar, and thank you very much, which is lovely to hear. Same with Melissa here. We'll just get the next one down here. So Paul's asked us, did you give any immune suppressive treatment to the cat with enteropathy? Obviously, prednisolone was not an option.
Well, we did give the cat prednisolone. It went very badly because the cat developed septic abdomen. Probably because it has such profound GI disease, maybe even small cell lymphoma, that you think about it, your intestinal tract has been infiltrated with lymphocytes that are abnormal. And when you give them a medication that kills those lymphocytes, the GI tract dies with it. And so that patient came back, was having a fever, and I was like, this is not a routine recheck. Scan its abdomen. Oh my goodness, fluid. Tap its abdomen. OMG, there is bacteria. Told the owner the cat is gonna die in 10,000 ways. Recommended in hospital, supportive therapy, antibiotics. The owner declined. The cat survived and has moved away. But that is a great question because now, whenever I use immunosuppressive medication, and we didn't even use an immunosuppressive dose of steroids, we used an anti-inflammatory dose of steroids for that cat, maybe just 1 milligram per kilogram per day, just because we needed to reduce the inflammation in the gut. But it went terribly. So I would always tell an owner that depending on the disease burden, you might get such a robust effect from your steroids that you might actually have, septic peritonitis. Like I tell them it can happen. It doesn't happen to all patients. I've used it in a lot of patients, but it was just this one that had DKA 3 times was the most challenging patient that we had. Yeah, there was also no way that we could optimize the diet. Had a lot of pushback from the owner who will not feed the diet that we want through the E-tube. So we couldn't optimize the diet with, we couldn't optimize the chronic enteropathy with just diet. And then we reached for some steroids. I held until the third DKA episode before I used steroids. But yeah, Paul, great question.
Thank you for
Challenging
that.
answer.
Yes, sounds very challenging.
It was
Um,
it was a nightmare.
oh no.
Nightmare.
Yeah, we all get those cases, yeah, for sure. So we've just a wee question to see if you could show the summary slide again. Is that
Mm-hmm.
possible? Can you find it?
Yes,
Amazing.
yes. Okay, all right. Let me just pop them all up. Okay.
There you go. It's not got a name on it, but hopefully you can get a little look at it there. We can just keep it up.
Mm-hmm.
So the next one here, in the last case example, is the diabetes transient and secondary to pancreatic inflammation, or is the diabetes an unrelated comorbidity? However, it's hard to control with the triaditis.
Oh, I think that I think that probably this is a patient with triaditis that kept getting flare-ups of its 3 components. And then, on top of probably it was very, very insulin antagonistic. So this is a patient, I will not use an SGLT2 inhibitor. This is one definitely we will use insulin because I don't know if this patient has enough intrinsic or endogenous insulin because it does have chronic pancreatitis. Yeah, but I think that they're very intertwined. Probably, I would think that the triaditis came first, and then that increased insulin antagonism. The cat is diabetic. On top of that, became a patient with DKA. They become DKA very quickly.
Perfect. No, that's really useful.
Hmm.
Thank you.
Yeah.
Next one we've got here, is it not possible to use the hydroxycobalamin via the subcutaneous route?
I think that the researchers that have been using it, that's Dr. Peter Cook, and the route that they recommended was intramuscular. The amount that they measure, I think the cobalamin in the serum level was also based on an intramuscular injection. I think in human, it's also an intramuscular route. So I don't think that at this time we have a subcutaneous protocol for the hydroxycobalamin.
Perfect. No, thank you very
But I
much for
think
that
it's
one. Yeah,
easy enough for you to try a sub-Q and then just measure the cobalamin and see if there is any effect.
perfect. Perfect.
hmm
I think you might have covered this one already, but just as maybe a short one. Do oral supplements work as effectively as injections in cats?
Yes, it does work. I think that Torreson's study actually looked at oral supplementation for cats, and it is as effective. Just for cats, the tablet is not very big, but I don't give my cats any tablet. I would give it gabapentin and it will froth in its mouth and it's like liquid. And I'm a veterinarian. I could give a pill pocket, but again, recognizing that pill pocket is not hydrolyzed. So kitty cats, I prefer to like just give them injection because you don't fight with them. Of course, I am also a veterinary professional, so I can give injections easily. So for an owner, yes, if they can get oral supplementation in, it's equally effective. I think that the underlying GI disease always has to be managed in tandem with the supplementation. But if your cat will take oral supplementation easily, yes, it works as well. In fact,
Perfect.
it works better for cats than for dogs because we're starting to see more in our lab, we're studying about cobalamin receptors, and we actually find that cats have more cobalamin receptors than dogs. And that's maybe the reason why their levels are always very high on supplementation orally.
Perfect. We'll need to
Yeah.
send you some Cabaliflex capsules because they open and sprinkle. So it might be an
Oh,
easier way
that's
than the tablets.
yes, that is lovely because then you can mix it in with a little bit of like, just their canned food,
Something tasty.
which can still be a hydrolyzed diet and you're not going to be
Yeah,
fighting with them. Yeah.
exactly. Exactly.
Mm-hmm.
So just another couple. I know we're running a little bit short on time, so I'm just going to pick up ones that maybe don't, haven't really covered.
Mm-hmm.
So do you have a rough time frame that you'll treat a patient with prednisolone for malabsorption before weaning down? Will you repeat blood work and want to see an improvement in clinical signs, weight gain, etc., before considering lowering the dose? So I think the idea of, we're looking at
Mm-hmm.
bloods as well as what clinical signs are doing.
Yes, I think that that's a great question. There is no cookie cutter medication. Um, like recipe that we could give you. And I think that it depends highly on the patient and the underlying disease. If you're dealing with protein losing enteropathy and you suspect that it's lymphangiectasia, you know that the inflammation is secondary to the primary lymphangiectasia rather than the inflammation is causing lymphatic, blockage. So in that case, I use an anti-inflammatory steroids like how you would use for a skin disease, a couple of days on 1 mg per kg per day, taper it down to 0.75 or zero point 0.5 mg per kg per day the next week. And then I taper it off pretty quickly, but I use it in tandem with the low fat diet. And I always tell the owner there are some patients that will not respond to just a low fat diet. They need to go on an ultra low fat diet. I tell them that from the very beginning because then if it doesn't work, then I look like I have told you everything. I've seen the future for your dog. And like, and you don't look silly rather than saying that, oh, I know you bought this bag of diet. It was very expensive. Unfortunately, it did not work. And we need to do this nutritional consult. So tell them from the very beginning.
Perfect.
So if your patient is one, I know Jay, we're running out of
No,
time,
it's fine.
but if your patient is one where they have used the spec lymphoplasmacytic, chronic enteritis that's not lymphangiectasia in nature, then in those cases, I Occasionally, I will choose to start them on immunosuppressive therapy if I feel that it's safe to be able to do that. And I don't do it for a very long time. So 1 to 2 weeks, get a repeat blood work. If they have biomarkers that you could follow, like low albumin, low cholesterol, then that's great. You follow those biomarkers. You can also follow just how the dog is eating, how the poop is looking. Are you having body weight improvement? All of those will tell you as a whole, the patient is doing better. And if that's better and the dog is tolerating at 2 milligram per kilogram per day, I may continue it a little bit longer if the response is not as great. But if the response is great, the dog is totally different, and the owner says, he is an asshole. He is a jerk because he's eating my food, which makes the diet trial really challenging, or he gets into my clothes, or he's eating cicada and cockroach outside, then you're like, okay, he has pica. And so this steroid is probably making him very, very, very hungry. Then I go down on the dose to a 1.5 milligram per kilogram per day. Now, when I say, does your patient tolerate it, it's because if I do see a patient that has evidence of GI bleeding, if I'm seeing melena from the very beginning, and that's a manifestation of their GI disease, if I'm seeing BUN to creatinine discordance, even if I don't see overt melena, I'm nervous in using a high dose of steroids because I know that's ulcerogenic. And I know that this patient may then have bleeding overtly from its GI tract because it doesn't tolerate the high dose of steroids. So in that case, I start with a 1 milligram per kilogram per day, or I start even lower at just zero point 0.5 milligram per kilogram per day. And I think about, do I need cyclosporin for this patient? Am I able to get him to have more appetite so that he can eat a diet, so that in case he does have a food sensitivity, that, taking away what is making his intestines unhappy, and at the same time giving him a little bit of anti-inflammatory steroids will help reduce that inflammation. So I'm always thinking about doing multiple things in a very strategic manner, but also thinking, is my patient able to tolerate steroids at a high dose? And is it showing side effects, and therefore it's going to get into like a foreign body and it's a surgery? Those are all really true things that has happened in our institution. And so I use all of that to help me to decide. And that's why there is no one answer. It really depends on what your patient is doing, what is it telling you, and what kind of risk the owners are willing to take with you. So very long
Perfect.
answer to a very short question.
No, that was great. Thank you so much. So I think we'll have to wrap up there. What I will do is send everyone the recording. And if you have any question that's not been answered, if you're happy with that, Sue, I'll forward them on to you. If there's
Hmm.
anything you didn't get tonight that we've not managed to answer, please do let me know, and we'll follow up with Sue for you and get those answers for you. But
Hmm.
thank you very, very much for a great session tonight. That was absolutely fantastic. I know a lot of people have been giving us feedback. They've really enjoyed the session. Thank you to everyone for coming. And I just think it's been really, really useful. And hopefully people have some fantastic tools to take back to practice. Okay,
Yes,
right.
thank you for the opportunity. It was a great session. Thanks for joining me.
Thank you so much. Right. Good night, everybody. Have a good evening. See you later. Bye bye.
Bye bye.